Hello guys, welcome to your online lecture for the thigh, hip, groin, and pelvis. I think it's always, it's innate in me to start with the basic anatomy. Even though I know that you guys have already had the anatomy component in gross anatomy, I think redundancy is sometimes better. So if this is too redundant for you, feel free to fast forward through this component of the lecture. But what I wanted to start with is a review of the bony anatomy. So we're looking at this skeleton here. And so what we can see is that we have the skeleton's left pelvis here. We have the skeleton's right pelvis there, right? So we have the ilium of each pelvis. We have the pubic bone, which is most anteriorly, right? And if we turn our skeleton around, then we have that ischium posteriorly, right? So we have three components to the pelvis itself. And so as we progress and we move distally, one of the things that you'll see is that femur, the proximal portion of the femur, is going to articulate with our pelvis, right? And it's going to articulate in this site right here, which is called the acetabulum, right? And you can see how it's a ball and socket kind of relationship, right? Where the head of the femur, see that? The head of the femur is rounded, and then the acetabulum is accepting that head. And it's a tight, intimate relationship between that head of the femur and the pelvis. And we see that the pelvis, in terms of structural integrity, is maintained by the ligaments. Do you see that? So there's a lot of ligamentous attachments that help hold the pelvis to the femur or the femur to the pelvis, depending on how you want to look at that. So it's very rare that you would dislocate a hip joint, but if you do, then that would be a medical emergency, right? So as I turn this skeleton around, we have our pelvis, which I mentioned, and then we have the femur, right, proximally, and then the anterior portion of the femur or the thigh, and then if we were to turn the skeleton around, then we'd be on the posterior aspect of the femur. And I'm sure by now in gross anatomy you've learned about the different muscular attachments, and so as we move through and progress through pathologies, what we're going to do is talk about each of those different muscles and the roles that they play in injury mechanism. But for now, let's just go through the ranges of motion that can occur at the hip and pelvis junction. The first one is going to be hip flexion. So patient's going to flex the hip, right? You can have hip extension, right? So hip moving backwards. You can have hip abduction, right? And then hip adduction. So imagine kicking a soccer ball. And then last but not least, you have rotary motions. So if I were to move my foot inward, you can kind of see how that femur is moving externally. So this would be external rotation of the femur. And then as I move my foot outwardly, you can see how that femur is kind of pointing down and inward. So this would be internal rotation of the femur. And we certainly could do that with the leg extended as well. So I could do this and internally rotate that femur, or I could go here, right, and externally rotate that femur as well. So we've got those motions at the hip. What we can see is that because the femur and the pelvis, which is called the coxofemoral joint, is a ball and socket joint, we have a huge amount of range of motion at this joint, right? And I don't know, I think we need that much motion, right? We needed to walk upstairs. Athletes needed to jump over hurdles, right? We can think of many ways in which we need increased range of motion at this joint in particular to allow us to do the things that we were built to do as human beings. So today's lecture is not going to focus on the anatomy as much as it's going to focus on the common injuries that you will see that plague the thigh, hip, groin, and pelvis regions. So without further ado, let's start with our first pathology. Our first pathology is going to be a quadriceps contusion. And so when we think about quadriceps contusions, we really have to start thinking like healthcare practitioners. I think that's what I really want to inspire you guys to do this summer, is to get away from thinking like lay people and to start thinking like your healthcare practitioners, because you are enrolled in a healthcare program that is preparing you to start practicing as soon as you graduate from our program. So when we think about quadriceps contusions, they have also been called quadriceps bruises, but I don't like that term. I like the idea of contusion because it describes the physiological process that's happening with our patients. We know about quadriceps contusions is that they most often happen from some type of impact, right? Most often that's a kick or a blow to the anterior thigh. It certainly could happen as you're walking around your house. If you've ever kind of bumped your thigh on a table or on the edge of a couch and you've had pain after that, then most likely you had a quadriceps contusion. But one of the things that I didn't know as a student in an athletic training program was that quadriceps contusions, just like strains, actually have grades, right? So grades of injury. So I kind of want to alert you to the most common types of grades that occur when someone has a contusion. So the most common type of quadriceps contusion is a superficial intramuscular contusion. So you can see that contusion is happening within the actual muscle itself, right? You can have a deep intramuscular contusion, right? Then you can have what's called an intermuscular contusion, which means that the contusion is happening between multiple muscles, right? And so these are muscles that you will actually label in gross anatomy, but these are all muscles of the thigh and the pelvis. And so what you can see is that bruise is going in between each of those muscles, right? Or you can have a mixed model where you have injury to the actual muscle, but then you have injury to the tissues between the muscles as well. And as you can imagine, the injury depiction in letter D is probably the most catastrophic, right? It's going to be the one that's most disabling to our patients. It's going to be the one that takes the longest to recover from. And so when we think about contusions, what I'm hoping is that you'll change the way that you're thinking. And instead of thinking, oh, it's just a bruise, it's no big deal, suck it up, we should be thinking about what tissue is injured, what tissue is compromised, how much of that tissue is compromised, and then look at levels of disability based on what you find in your clinical presentation. So in terms of the signs and symptoms, yes, pain, but when we're thinking about pain, it's going to be pain with knee flexion, and let me show you why. So when we look at this skeletal structure, one of the things that you're going to see with this skeletal structure is that the quadriceps attach where, you guys? To the anterior portion of the femur. We know that the rectus fem comes up and it has an attachment site to the anterior inferior iliac spine, right? And then the other quadriceps muscles by way of the quadriceps tendon have an attachment to the superior pole of the patella. We all agree there. Okay, so when I say pain, they're going to have pain to touch, obviously in the contused region, but they're also going to have pain with knee flexion range of motion. And the reason for that is what you guys can see here in this skeletal model is if I flex my knee, I'm going to be stretching the quadriceps mechanism, which is going to elicit pain in our patient, right? And then when we get into letters C and D, so that intermuscular contusion or that mixed contusion, what we typically see with our patients is they lose function. So in other words, the quadriceps aren't contracting like they're supposed to concentrically and eccentrically. And so as a result, what we have to do is remove that patient from practice or participation because there's a huge risk for increased injury because they're not able to move the way that they normally would have moved in participation. What you will also see with this patient is some type of effusion or swelling, and then pain to palpation, right? So we want to look at the patient's thigh, want to assess it. We want to assess range of motion. We want to assess strength of the quadriceps to help us determine whether or not this is a superficial injury or whether or not it's a deep injury, right? Again, I've dealt with athletes who have had deep quadriceps contusions, and what we've also seen is with those deeper quadriceps contusions is that the femur also gets contused as well. So you have, not only do you have a muscular contusion, but you have a bony contusion. And if that's the case, then what we see is that patients could be out 4 to 8 weeks with just a simple bone contusion. And so we have to be able to use our clinical tools to assess this pathology to help us determine what their treatment paradigm might actually be. So in terms of the management, I put this image here because it truly is what we want to do, right? Remember, I just showed you on our skeleton here that when they flex the knee, they have pain because we're stretching the quadriceps mechanism, right? But interestingly enough, one of the recommended treatments is to actually place the patient in a knee flex position with ice on them and an ACE wrap. And the reason for that is we're forcing them into a knee flex position because what we know about quadriceps contusions is that, believe it or not, our patients have quadriceps contractures, and so it becomes hard to get them into a knee flexion moment. So if we start improving knee flexion right away, we have less work to do on our end to regain that knee flexion range of motion that is most often lost after a quadriceps contusion. Other things that we do with quadriceps contusions, you guys, we do a few other things. We rest, ice, and compress, right? We use crutches in the event that it's that mixed quad contusion, in the event that they have a bone contusion, a femoral bone contusion, right? And in the event that there is a massive amount of swelling on the anterior thigh, right? Because at that point, just think about the lower limb. We talked about a compartment syndrome in the lower limb, right? Well, can we have a compartment syndrome in the anterior thigh? Most certainly, right? Because what you guys should have learned in gross anatomy is that the femoral artery, right, runs through the anterior thigh. And so if there's a lot of swelling on the anterior thigh, it's going to compress on that femoral artery. So just be careful with these injuries that seem like they're minimal, because they certainly can lead to medical emergency over time. And so that leads me to bullet point number 3, which is this aspiration of the hematoma. So if the hematoma, a blood fluid filled sac, gets large enough, physician will go in and aspirate and take that fluid out of the anterior thigh in hopes to avoid creating a compartment syndrome. And then the recommendation for student athletes who return to participation is actually to pad them. Because when you pad them, what we're doing is reducing the impact or the next impact, right? We're going to talk about a sequela injury that occurs when a patient continues to take repeated blows to the anterior thigh. Okay, so that is a quad contusion. The next pathology that we're talking about here then is myositis ossificans. Say that a couple times, right? Myositis ossificans. Here's the etiology. The etiology is there is increased bone growth within the actual muscle itself, or what your textbook would call is like ossification, right? Ossification, hardening of tissues after repeated traumas. So now let's go back to our quadriceps contusion slide where I said we want to pad them. Anytime we have a quadriceps contusion, we want to pad them to reduce the number of repeat traumas, because if we don't pad them and if we don't protect the area that's exposed, then what we see is the development of myositis ossificans. Okay, so it is the ossification of tissue within a muscular structure, so the hardening of tissue within a muscular structure. In this case, it's going to be the quadriceps, and it most often occurs after you improperly treat the thigh contusion. So what am I saying to you? I'm saying if we treat our quadriceps contusions correctly when they come in, most often they don't progress to myositis ossificans. If we pad them, if we put them in that knee flexion angle right away, even though it's painful, then most often it doesn't progress to myositis ossificans. So what are the signs and symptoms of myositis ossificans? They are very similar to a quad contusion, with the major differential being on x-ray, you'll see calcium deposits within the actual muscle itself. So this white part should not be here. Do you see this? This is the other side. This is the hamstring, right? And so what we see here is the ossifications of the quadriceps muscles in this particular image. We don't see that there. It should look like this, but it doesn't, right? So we have a massive amount of ossifications. The other thing that we see, which is similar to a quad contusion, is pain and weakness and decreased range of motion, in particular in knee flexion. And so what happens is as that patient flexes their knee, the muscle slides over those ossifications and it causes a massive amount of pain. Just think about shards of glass living in your muscle belly and then having to move that muscle belly over those shards of glass every single time. It's kind of a good depiction of what a patient with myositis ossificans feels when they are going through movement. So be mindful of that. In terms of management for myositis ossificans, it's actually treated very conservatively and can most often kind of go away or resolve itself if we treat it correctly. So icing initially with that knee flexion moment, some heat, and then the recommendation is therapeutic ultrasound. And so we're going to do therapeutic ultrasound with that patient. But if they continue to not get better, if they continue to live life in a lot of increased pain, then we have to basically go into surgery. Now, I don't show you images here of what surgery looks like, but imagine making an incision from the anterior superior iliac spine all the way down to the quadriceps tendon, and then reflecting back both sides of the muscle and just pulling out the little pieces or ossifications, right? So what we have is less, think about that, less quadriceps muscle tissue, which means what for our patients? They're going to be weaker, right, on that injured side, right, because they're losing muscle tissue. So their manual muscle task may never be 100%. Does that make sense, guys? So what am I saying here with this particular pathology? Treat the quadriceps contusion very aggressively and pad them when they return to play if they are an athlete who lives in an increased, reduced risk for quadriceps contusion. And so when I think about what athletes those are our field hockey student athletes. Those are some of our football student athletes. Those are our some of our basketball athletes, especially if defensive and you keep getting kneed as you're defensively sliding. So know which sports are going to be high contact at the quadriceps. It's also going to be our soccer athletes. Probably see myositis ossificans the most in our student soccer athletes. Know which sports are at an increased risk. And when they walk into your clinic with quadriceps contusion, you're going to treat them a little bit differently than you might someone who just bumped their leg on their table in their house. Okay? All right. So as we progress in terms of quadriceps injuries, the least catastrophic is a quadriceps strain. So what do we know about the etiology of strains in general? Either we have one of two things happening. Either there was a rapid stretch to the quadriceps muscle, right? So you quickly flex your knee, and as a result, it stretched the quadriceps because they weren't ready to protect you. Or the opposite of that, you move into a knee extension moment and you overcontract the muscle, and it causes the muscle to stretch and tear, right? So you can have either. What happens most often, the most common mechanism of injury is going to be the rapid stretch, but it certainly could happen with contraction as well. In terms of signs and symptoms, here's what I'm going to tell you. If I tell you nothing else, if you remember nothing else from this lecture, this is the key to assessing any strain in the human body. If a patient complains of pain with active contraction, meaning they're doing it, and passive stretch, meaning we are doing it as clinicians, then they have some form of strain. Now, what type of strain or what grade of strain is to be determined. Let me say that again. For a quadriceps strain, if a patient extends their knee, right, and they have pain, and then we flex the knee, right, and they have pain, then that they have some sort of strain. It could be a grade 1, it could be a grade 2, it could be a grade 3, but what we know 100% of the time is if they have pain with active contraction and passive stretch, they have a strain. And that goes for any muscle in the entire human body. So I won't repeat that again. In terms of their signs and symptoms, most often they're going to be tendon palpation in the muscle belly in the area of the strain. They may have some sort of spasming as a protective mechanism around the actual strain itself. And depending on the grade, they may have loss of function. So most often, loss of function, ecchymosis, deformity, those are most often going to be associated with your grade 2s and grade 3s, whereas your tendinous palpation and maybe pain with movement is going to occur with your grade 1, right? And we recall that a grade 1 just means there's stretching of the tissue, but a grade 2, we actually have that tearing, and then a grade 3 would be a complete rupturing of those muscular structures. Okay, so what do we do for patients with quadriceps strain? I think most of us by now know this, but just for review, we are going to treat the swelling, we're going to compress them, we're going to put them on crutches, right? That would be rule number 1. And then other things that we want to do is strengthen the supporting structures. So our adductor muscle group, our abductor muscle group, right? Our hamstring muscle groups want to strengthen those muscles surrounding the injured muscle. And then if they return to play, what we want to do is put a neoprene sleeve on, because what that does is it increases heat, which is increasing blood flow to the muscle. So it's a good thing for a strained muscle. And then we want to strengthen. Now, there are many techniques used to strengthen the quadriceps muscle. And since this is a seminar beginning course, I will not go through those, but you will get tons of rehab plans for student athletes in your therapeutic exercise and advanced therapeutic interventions courses. The hamstring strain is up next. In terms of how do we injure this? It's typically overload from, you ready? It's hip extension and knee flexion moment, okay? So what does that mean exactly? You ready? So essentially, let's see if I can show you on the cadaver. So essentially what happens is, Go down right there. Okay, so what we essentially will see is if we're going here into hip extension and the knee is flexed, sorry guys, there we go, and the knee is flexed, what are we getting? Is that over contraction or over stretch? What do you guys think? So if I extend the hip, right, and flex the knee, what's happening here? Right, it's over contraction. Now, could we certainly get an injury to the hamstrings by flexing the hip and flexing the knee? Yeah, because that would be stretching, right, of the hamstrings. But most often, hamstring injuries are going to occur in a hyper-contracted state, which is a little bit different than its sister muscle group, right, the quadriceps. What we know about quadriceps versus hamstrings is there's far more hamstring strains than there are quadriceps strains. The other etiology, quite honestly, is just a lack of flexibility in our patients who come to us, right? And I'm honestly thinking of our cross-country runners, our football athletes, right? Ask them to just do hip flexion. And I bet you probably wouldn't even get to about 20 degrees of hip flexion, right? So we have to work on, as clinicians, kind of assessing those patients that are at high risk, right? And then figuring out a way to increase their flexibility to reduce the risk of hamstring strain. In terms of signs and symptoms, they're going to have pain or tenderness in the area of the strain, certainly loss of function in knee flexion or concentric contraction, and last but not least, depending on the grade, they could certainly have some ecchymosis, right, some bleeding in the area of the strain. So grade 1 with the hamstring strain, they're going to have soreness during knee flexion moments, maybe even hip flexion moments with knee extension, and tenderness to palpation. But with a grade 2 and a grade 3, this is where we kind of want to hone in, right? With a grade 2, remember, it's that partial tear. They may or may not feel a pop, but they will have severe pain and they will not be able to function 100%. Might be able to do some pieces or components of their activity, but not all. And then a grade 3, you're really concerned because most often what we know about the hamstring muscles, right, you guys, what we know about them is they attach where on the pelvis? Where do they attach on the pelvis? You guys tell me. Did you say the ischial tuberosity, right? And so one of the things that we know about hamstring strains is, number 1, you can have 3 different types of tears. You can have a proximal avulsion off of the ischial tuberosity. You could have a mid-substance tear. Yeah, he's stuck. You could have a mid-substance tear, right? So right here. Or you could have a distal tear, right, at their distal attachment site on the tibia or the fibula, right? So there are 3 different areas that you as clinicians will need to palpate in order to make sure that you are assessing the entire hamstring muscle. Now, certainly there are other parts of our assessment that we should be doing, such as manual muscle testing, right? As strength testing will be a component. But certainly we should first start with our history, our observation, our palpation, before we move into our special testing component. Okay? All right, so in terms of management, these are just some simple exercises that you can do post-hamstring strain just to get you started. For those of you that are not strength and conditioning coaches or personal trainers, you're looking for some just simple exercises to trigger the hamstring. These certainly can be progressed and made more difficult, but this would be an example of a rehab protocol that you could put into place. Certainly should be progressing to sports-specific activities as that athlete progresses to return to play. But initially what you want to do is rest that hamstring muscle group. Allow that tissue to heal itself so that it isn't weak and doesn't continue to be restrained over time. And most often, if there is ecchymosis or swelling associated with that injury, NSAIDs are going to be the drug of choice. With grade 2 and grade 3, particularly in our track and field athletes, we want that gradual return to stretching. Our temptation as clinicians is to stretch, stretch, stretch. But a strain is essentially a stretching of a tissue, so we want to avoid lots of stretching with this particular patient, at least lots of stretching of the hamstring muscle group. Certainly can stretch the quads or the AB ductors or the AD ductors, but try to avoid stretching that hamstring muscle group to allow that muscle and that tissue to tack back down. And then you return them to play, and that sounds easier said than done. Worked track for 8 years, and so this is the one injury that I saw the most in my career working with track athletes. And again, it's like the contusion. You would think it's so simple, it's something easy to manage, But if you have a hurdler and it's their lead leg, it's not as easy as you would think to manage. It's taken 12 weeks to return a grade 2 hamstring strain because every time they go over the hurdle, they're stretching that hamstring muscle group. So in the meantime, what we want to do, our job is to strengthen the pelvis, strengthen the core, strengthen the muscles surrounding, right? Work on strengthening the hamstring that was injured, avoid stretching too much until all of the tissue has resolved itself. And then overall bigger global plan would be to work on a stretching protocol for that particular patient. Okay, we're moving to some acute traumatic injuries, and the first one is an acute femoral fracture. I think this one's pretty straightforward. How does it happen? Most often it's a direct blow to the femur, and so what you're seeing here in this image is that the femur fractures, right? And the scariest part about a femoral fracture is going to be that when it fractures, what you'll see here is the quadriceps contract to protect that patient. What happens when the quadriceps contract is what you see here. So at first, they're not as contracted, right? And so those bones look somewhat aligned. But then when we look at this image on the right, what you see is they're in full contraction now. And so what they've done is they pulled those bones across one another. And so it actually makes the fracture worse. It displaces it. So this is a medical emergency. I think I'll say that a few times throughout this this particular slide. But what are the signs and symptoms? Well, number one, it's going to be that you'll see a deformity. Number one, from the quadriceps contracting, and then number two, you might actually have a deformity of the femur, depending on how much it's displaced. You'll have what's called crepitus if the patient's moving, which they shouldn't, right? We should be immobilizing them. I can't wait until we can do that in class. But you should immobilize them, and then they're going to be in a lot of pain. The hard part will be that you will want to give them medication, and you can't. So your only job is to do this right here. You're going to treat for shock. You're going to check their circulation distally to make sure that blood flow is still going down to the lower limb and the foot. You're going to splint, and then you're going to refer them to ER. And in the ER, it's pretty cool. They reduce the femur. And so sometimes they have to actually put the patient under. Other times they're able to get that patient to relax. But you'd be surprised. I've watched, if you want, YouTube it. I've watched physicians with teams of people trying to pull the limb to relocate the femur. So most often they have to go under in order to overcome the contraction of the quadriceps muscle. I will say one time it is a medical emergency. With femoral stress fractures, it's a little bit different, right? This isn't an acute traumatic injury where we're concerned about the patient's life or limb. And so we treat femoral stress fractures a lot different than we would an acute femoral fracture itself. The etiology, like all stress fractures, is going to be overuse. We see this most often, though, in our jumping and running sports, in particular, those cross-country teams or track and field teams who do downhill training. It loads, in particular, it loads that femoral head and that femoral neck more than is usual. And so we'll see that femoral neck kind of give way. And so what we know about femoral fractures is that they're more common in women than in men, and the most common fractured site would be the femoral neck, and the second most common fractured site would be mid-femoral shaft, right? So what are the signs and symptoms? I'll tell you differentials. I mean, obviously they're going to have lots of pain, right? One of the differentials is unexpected pain in the groin region that comes out of nowhere. So they don't hyperstretch it, they don't strain their groin, but for some reason they're having this intense sharp pain in the groin region. And then you guys already know the answer to this. What's the number one sign and symptom for stress fractures? Right? It's that night pain. So again, I have it here. You're starting to see commonalities across injuries, right? So it's that night pain. They'll have a positive hop test. So I don't think I've shown this, but essentially the hop test. What you want to do is have that patient hop on that injured limb 5 times, right? And it's not like a simple hop. We're talking like, I'll put the camera down just a tad bit. We're talking about a hop that's relatively high off the ground, right? If that patient has a femoral neck stress fracture, you guys, I can guarantee that they won't even get through 2 hops before they fall down to the ground. So in terms of the hop test, they have to be able to hop 5 times in a row for it to be negative, right? So a positive would be 1 through 4 jumps. If they don't make it to 5, then that's considered a positive. We refer out. And then I'll show you what a torque test looks like when we get into lower extremity class. The only way we can diagnose a stress fracture is through one of the imaging techniques that you'll see down here. Most often a bone scan or an MRI will reveal the fracture, and an x-ray will tell us if the fracture is actually healing itself. So if we're looking at that, if you see here, right, it's a bone scan. You can see that fracture there, and then on an x-ray, we're seeing it here as it's starting to heal itself. So in terms of management, this is the one stress fracture that probably takes the longest to resolve itself. It requires rest for at minimum 2 months. And then at length, 5 months. I will tell you, I've had a student athlete out for an entire 1.5 years with a femoral neck stress fracture. So it's going to vary, but what do you know about femoral stress fractures is they take longer. Why? Where is force transferred from the lower limb to the femur, right? So it is a massive weight-bearing bone, and so we have to allow it to rest so that it doesn't become a full through and through fracture, okay? What are some things that we can creatively do? Because 2 to 5 months of being out and doing nothing can be very discouraging to our patients. And so some of the things that we've seen in the clinical setting is swimming, biking, right? And then the newest thing on the market are those underwater ultra G gravity underwater treadmills, which have been amazing to use in the clinical setting. I believe San Diego State has one, not certain about UCSD or USD. Okay, and then as we progress them to running or their sport, we want to start with a softer surface first. So progress them from grass, right? Makes sense, to track, and then maybe to cement or dirt. So softer surface to harder surface as they begin to return to play. Okay, groin strains are just like our hamstring strains, are just like our quadriceps strains. The only thing different is the etiology. The etiology is most often going to be a hyper-abduction moment coupled with external rotation. So a massive stretching moment, right? You guys could imagine that, right? If I swing my leg out and then kind of throw my foot in while my leg is out, I'm going to injure the groin region or the adductor region. Most often, groin injuries are seen in running sports, but in particular, running sports that require quick cuts. So soccer, thinking of soccer, and I'm thinking of basketball, and I'm thinking of volleyball with this particular injury, but certainly could happen in any other sport as well. In terms of signs and symptoms, they are pretty much the same. I'm going to go with what I told you. I'm going to look down here and I'm going to say, do they have pain with active contraction, right, and passive stretch? So ready? If I actively contract and move into adduction, do I have pain? And when you take their leg into hip abduction and stretch them, do they have pain? If the answer is yes to both of those, then more than likely they have a strain, right? The question just really becomes, what grade of strain is it? Make sense, guys? So we could look at other strains with this same lens, right? A hip flexor strain, we know that most often hip flexor strains can either occur with hyper hip flexion, but most often they're going to occur with a hyper extended hip motion, right? So we can imagine if this is our patient, right? They're going to report to us and they're going to say, oh man, I was warming up today, and for some reason I went all the way back like this, right? And now I have a pain right here, anteriorly, right? I have this anterior pain that I just can't shake. And so that we would consider to be a hip flexor strain. And in terms of signs and symptoms, they're going to have pain on the anterior portion of the thigh, right? Because when we're talking hip flexors, that's such a general term. That could be rectus femoris, or that could be sartorius, sorry. That could be rectus femoris, right? That could be iliacus or psoas up here. It could be a lot of different things, right? But what we know about hip flexor strains is they have to have pain with hip flexion actively, right? And hip extension, passively. And if they do, then we're thinking it's a hip flexor strain. So you guys can see what I'm telling you, I hope, is that any strain, have the patient actively contract and then you passively stretch it. And if it's positive both ways, then they have a strain. The question just becomes, how functional are they? How painful are they? And how much swelling do they have, right? Because that will then help you determine what grade of strain they have and help you determine return to play protocol. So with a groin strain, in terms of management, it's similar to the other strains that we've talked about. rice, NSAIDs, and then the biggest deal with adductor strains is you delay exercise until they're pain-free, and here's why. What we know about the hamstrings, the adductors, right? You guys, let's take a look at this. What we know about the adductors, and let's see if I can get a good image. So what we know about the adductor muscles is this right here. We know that, yay, it fell. Okay, we know that they attach on the medial side of the femur, right? We know that they come up and they have an attachment to the pubic bone, right? So if we have an adductor strain that's proximal, what we also run the risk of doing is creating some type of irritation to the pubic bone, to the osteitis pubis. And so it's one of the reasons that with this particular injury, we want to delay, right? Return to exercise until they're actually pain-free, okay? In the meantime, what we can do as clinicians is we can kind of work on restoring normal range of motion and strength. And strength, when I say strength, I mean not just of the adductor muscles, but of the muscles surrounding that particular muscle group. And then we can provide support by doing what? By splinting them with an A strap, which your guys are going to do this week. You're going to learn how to tape for a hip flexor strain and an adductor strain. Okay, so hip pointers, I think this one is pretty straightforward. In terms of hip pointers, what we're saying is that the patient took a direct blow to the ilium. So, right, if we're looking at this here, the patient took a direct blow right here. Took a direct blow, boom, right here, right? Happens in football all the time. Happens in soccer all the time, especially when they're slide tackling, right? And so what we're saying is that there is a contusion of the iliac crest, right, of that particular patient. Sometimes that contusion can actually happen a little bit to that distal portion of the abdominal musculature, okay? So what are the signs and symptoms of a hip pointer? Most often what you'll see is spasming of the hip abductor muscles. Because guess what? If there was a direct blow, now I'm in pain. And one of the protective mechanisms, you guys, is to do what? It's to spasm, to protect that particular joint from more injury, from more use. And so that's why we spasm, right? So that is a sign and a symptom. So the other sign and symptom is just tenderness to palpation on that iliac crest. But if you see something that looks like this, right? Do you need to palpate it? Like, if you're really asking yourself the question, do you need to palpate it? The answer would be no. We see ecchymosis, we see swelling, right? We see all of those signs. So there's really no need to palpate that structure, right? So be careful in your clinical evaluations to not do things that you don't have to do. So in terms of management of a hip pointer, it's very similar to that of a quadriceps contusion. You're going to rice for at least 48 hours. Give them some NSAIDs if they're in pain and if they have swelling. And then one of the concerns with hip pointer injuries is this idea that because the ilium is so bony and is it protected by as much musculature, what we tend to see is that when we take a direct blow to such a bony region, that in fact you could have some type of fracture. So if you're concerned about that, just refer out, get them an x-ray to make sure that there isn't a fracture. Most often there isn't, but you still have to be concerned because this bony region of the pelvis is absolutely exposed. Then we want to ice massage, right? So think about icing and massaging all in one. And then sometimes what we have to do, depending on if that swelling gets into the joint, and if that joint gets stiff, then we'll do like a cortisone injection to just reduce the inflammation and get that hip joint moving all over again. Most often, athletes will recover from a hip contusion within 1 to 3 weeks. Sometimes they resolve themselves even sooner. And by recovery, what I mean is they will have less symptoms, right? Doesn't mean we have to keep them out for 1 to 3 weeks, but they might be limited to pain. They might not be able to function as well for about 1 to 3 weeks, okay? Okay, we have a pathology called osteitis pubis, and I think it's important because we are working in sports in the fall where this pathology will plague you. One of those sports is volleyball, believe it or not, in particular with our libero. So I'm going to get this skeleton in the right position so that you can actually see it. Okay, so the osteitis pubis, let's define anatomically where that is. We have pelvis 1, pelvis 2. We have pubic bone 1, pubic bone 2. And then in between there is a small little disc. Okay, you see it there? And the major role of that disc, just like the cartilage or meniscus in the knee, is to prevent friction and rubbing of the two pelvis or the two pubic bones. It's also to reduce the amount of shock or force going through the pelvis, right? Imagine if I'm jumping, if I'm landing, right? This is going to absorb some of the shock. So in osteitis pubis, essentially what happens is repetitive stress to the pubic symphysis by way of the adductor. So imagine if you have an athlete who's always in an adducted position, right? So they're always in an adducted position. We could think soccer. We could think basketball, defensive slide wise, right? So if they're always in an adducted position, essentially what happens is there's a lot of stress being placed on what? The pubic bone, in particular the disc that sits in between the two pubic bones. And so what we know is that because of that, one of the concerns is that this joint will become unstable, if that makes sense, right? And if it becomes unstable, then the concern is, do we have movement of the actual pelvis bones? And what does that mean for injury down the chain or up the chain, right? So in individuals who have an adductor strain, we also want to rule out, believe it or not, a pubic injury, right? And in this PowerPoint, what we can see is the relationship of those medial muscles to the pubic bone itself, right? We can see how they all have some type of pull or attachment to the pubic bone itself. And so as a result, any injury to them could secondarily lead to an osteitis pubis, right? So what is an osteitis pubis? Inflammation of what? This joint right here, okay? In terms of signs and symptoms, most often you're going to have, your patient's going to complain of pain, a deep-seated groin pain, if there's groin injury, and then they're going to complain of pain in their actual pubic region. So they're going to complain of pain right here. Now, that brings me to the point in the lecture, right, where you all go, what? Right? I might have to actually palpate a pubic symphysis. And so the answer is possibly, right? It depends on how comfortable you are with that. In the clinical setting, if you are uncomfortable palpating the pubic bone of a student athlete, then you refer it out to your preceptor. But when you become certified, you have to do it, right? And so one of the ways that I've learned to do it in the clinical setting was to have the athlete do it, to teach them how to do it on themselves. And then that way it reduces the risk of being held liable for touching someone inappropriately, right? So if you are uncomfortable with a palpation as sensitive as the osteitis pubis or the pubic symphysis, then what I would recommend is teaching your athlete or instructing the athlete on yourself so that they can tell you if they have pain in that area by touching themselves, okay? So they're going to be point tender right here, right on this pubic tubercle, okay, guys? In terms of management, it's rest. It's taking off the stress from the adductor muscles, right, so that they're not pulling on the pubic bone. And then sadly, it's a progressive return to play with a symptom checklist every 2 or 3 days until they are pain-free. Okay, next is athletic pubalgia, which is essentially like a sports hernia, right? And so what we know about sports hernias is most often, you can't see those muscles here, they're going to plague the abdominal muscles. So what we know is there are repetitive stressors to the pubic symphysis potentially, to the abdominal muscles. And so what we typically will see in this particular injury are those micro tears of the rectus abdominis, the hip adductors, or the abdominal oblique. So it could be any or all of the above. What we most commonly see, however, are rectus abdominis tears, so tears right in this particular region. And so what we see is a tear, and so then you have intestines that are able to protrude through that muscle, right? And that becomes a concern because when that muscle contracts, guess what? It's going to impinge the intestines. So signs and symptoms, they're going to be very chronic, but what we know is that patients will typically report some type of sharp pain in the abdominal region, and if it's the hip adductors, then into the hip adductors as well. They may have tenderness to palpation on the the pubic tubercle, right? So right in this pubic symphysis region. And if it's hip adductors, they're gonna have pain. Look at me. When you resist, so hand here, you're resisting hip adduction, okay? You're resisting that. coupled with a resistance of a crunch, right? So imagine an athlete's doing a crunch, you're resisting here while you're resisting hip movements, okay? So what do we do for these particular patients? There's a lot of things that we can do. I'll just tell you what's recommended. If you palpate the abdominal region and you feel a deformity, it's a referral out. Most often what they're going to do is go in laparoscopically and repair that particular hernia. And then what you'll have to do is do some light core work, which will progress to more core strengthening components, right? And then you'll work on strengthening glutes posteriorly, hamstrings posteriorly, and then quadriceps and adductor muscles anterior and medially as well. What we know about athletic pubalgia in general is that it takes about 6 to 10 months to heal itself, especially if that patient has had surgery. But if you're really trying to allow that muscle, whether it's here in the rectus abdominis or down in the adductor region, in order to allow it to heal, in order for the blood flow to come in and allow for that muscle to resolve itself, will take about 6 to 10 months. So want to avoid athletic pubalgia. One of the ways to do that is to make sure that our athletes don't have strong abdominal muscles, yet weak hip flexors or weak hip extenders or weak hip adductors, right? Because when one of our muscular systems is off, guess what happens? Most often what we could say is that something else is going to take over for that weak link, right? So making sure that when we do our pre-participation physical examinations or our team strengthening assessment, that we're identifying weak links and we're working on strengthening those weak links as our athletes come into us in the clinical setting. So this is an example of a sports hernia in terms of laparoscopic repair. I mean, it's pretty minimally invasive. I say that to say that certainly there are 3 different cameras in there, but you can see that the incision is going to be relatively small, right? And they're just going to repair that. So you can see right here we have the rectus abdominis muscle, and if there's an injury to that, compromise to that, then the intestines can protrude, and that becomes a really big concern for our student athletes. Okay, so trochanteric bursitis. Trochanteric bursitis, as the name implies, is inflammation of the trochanter bursa. So imagine we're living here. Let's see if I can get you in the right position. So we're living here. So here's the trochanter. What we know is glute med will live right here if we're envisioning that. You can kind of see it on your image here. And so then in between the glute med and the greater trochanter is a bursa that lives right about here. And its major role is to do what? Prevent bumping of this bone up against other structures, but also to prevent friction of the glute med, right? Over in the iliotibial band, essentially, to prevent friction of those 2 muscles over the greater trochanter. But what happens is, if in fact the glute medius is, or the IT band are tight, then they will rub against this greater trochanter, causing a friction, which will lead to an inflammation of the bursa. And so the bursa, essentially in this pathology, what it's doing is it's inflating like a balloon to protect us, right? To protect us from bony injury itself. So the signs and symptoms are going to be tenderness to palpation right over this greater trochanter, so laterally, and then pain with hip adduction and abduction as that hip is kind of moving. And you'll also see it in hip flexion and extension as well, because the IT band and the glute med might also slip over that greater trochanter itself. So what we want to do is we want to essentially rice and then NSAIDs, of course. And then the biggest thing with this that I've seen is it's a flexibility issue and a biomechanical issue, right? And so we're talking Q angle here really quick. It's the angle of the hip in relationship to the knee and the pelvis. We know is that females typically have wider Q angles, which ultimately sets them up for more injury to the greater trochanter, and they are usually most often plagued by trochanteric bursitis. See it most often in our running sports, in particular in our cross-country student athletes. A dislocated hip. I'm not sure what to say here. It's usually acute traumatic, but it rarely occurs in sport. I think the only time that I've known of a reported dislocated hip was Bo Jackson. so I'm probably giving my age away there, but Bo Jackson was the first athlete to have suffered from a dislocated hip, and in his case, he actually ended up losing the hip and had to actually get a complete hip replacement because blood flow was compromised and cut off. So what am I saying? It's like childbirth. It rarely happens. It's rarely going to happen to you, but it occurs as a result of a traumatic force. Remember I said there are lots of ligaments restraining this femoral head in this pelvis acetabulum socket, right? And so what we can say, let's say it this way, is that these are very rare, but if they happen, they are catastrophic. Your athlete can absolutely lose a limb. So what is the sign and symptom that your patient has a dislocated hip? Number one, they are going to be, you ready? In hip flexion, they are going to be adducted, and they are going to have an internally rotated hip. So if you could imagine a position like this, if you run out to the field after an athlete has been tackled and falls down, if their limb is like this, most likely they have a hip dislocation. That's a 911 call, right? You're going to stabilize that patient, reduce for shock, and you are just going to sit there and hold their hand and get them through until EMS arrives to treat them. Okay, guys? So in terms of management, it's an immediate referral. The only thing that you're going to do, maybe if you can, is splint it, but most often you cannot splint. What you will not do and should not do is relocate, because what we know about the pelvis, which you all know, is there are lots of intimate arteries and veins, right, that run through the femoral head and the pelvis, and so we don't want to touch it. Leave it as it is, call 911 and let EMS deal with it. So after it's relocated, essentially, what happens is that patient is going to be immobilized for about 2 weeks and on crutches for another 4. It's about a 6 to 8 week recovery. That said, one of the things that we see most often with a hip dislocation is if the hip dislocates, sometimes you have a fracturing of the actual posterior socket of the pelvis. So if that actually gets fractured in the dislocation, then certainly that's going to take a lot longer, right, you guys, than 6 weeks to heal itself. So these times I'm giving you are just the standard, but every patient in the clinical setting is going to present so differently. Okay, that concludes our thigh, hip, pelvis, groin lecture. I hope that you guys have learned a lot. I know that these lectures are long, and I sometimes think I should break them up, but I know that this is the best way to do it because they are all combined and they're all in one. So I look forward to your responses on the required homework assignment as you're watching this. Please feel free to rewind. Hope you all have a good week.